Good morning, welcome to another net tutorials. And today we're going to be talking about management of malaria and complications. So we all know what malaria is. Malaria is a parasitic infection that's caused by the genus Plasmodium, which various species have the Plasmodium vivax, Plasmodium ovale, have the Plasmodium malaria, or have the Plasmodium falciparum. These are the most common species. We also have the Plasmodium knowlesi. The one that is more endemic to West Africa is the Plasmodium falciparum. So Plasmodium falciparum is transmitted by a vector, which is the female Anopheles mosquito, and man is the reservoir of this organism, and man is also the susceptible host. Alright. So the incubation period, which is the time between introduction of the infectious agent and the development of symptoms. Okay, it varies between the species of the parasites. During the incubation period can help rule out malaria as a cause of fever. Now the incubation period usually for falciparum is 9 to 14 days, for vivax is 12 to 17 days, for ovale is 6 to 18, and for malaria is 18 to 40. But take note, viva and ovale can exist in what they call hypnozoids, in which they stay in the liver asymptomatically without causing anything. But these hypnozoids could cause reinfection and reoccurrence of symptoms over after a long period of time, can even be up to almost 9 months. So this is the basic life cycle. So what happens? Malaria takes a blood meal. Sorry, the mosquito takes a blood meal and injects the sporozoites. The sporozoites then migrate to the liver and infect the hepatocytes. Okay. Now within the liver, they begin to multiply, and here they are called merozoites. Then they form schizons. Now the liver phase is called the exoerythrocytic phase. Now when the schizons rupture, they release multiple merozoites, which then infect red blood cells. Now within red blood cells, they become trophozoites. Okay, they form ring stages, which are termed the immature trophozoites. The immature trophozoites form the ring stages. This is what we see in peripheral blood smear. Then they mature. Now when they mature, they also form schizons, which is multiple trophozoites present within the red blood cell. Now when the schizons rupture, the rupture of the schizons is what gives us the clinical presentation of malaria. Okay, so every time each schizons rupture, there's marked systemic inflammation. So we get our fever, our chills, headache, nausea, vomiting, and so on and so forth. Also, the trophocytes could fall another part in which they become gametocytes, which is male and female gametocytes. Okay, prior to this, every form of reproduction that the plasmodium undergoes is what? Asexual reproduction. Alright? Good. So the gametocytes now, when mosquito comes and bites an infected person, it takes the gametocytes. The gametocytes then undergo sexual reproduction within the mosquito. So if you see a question given a clinical history of malaria and then they ask the vector for this organism, what stage of reproduction occurs with these vectors? You know, it's the sexual stage, while the reservoir or host is the asexual stage occurs. So sexual reproduction occurs, which includes the fusion of the male and female gametes, which then gives us zygotes, ookinete, oocytes, and then forms a cyst. The cyst now ruptures releasing sporozoids. Sporozoids then go to the mosquito salivary tract or mosquito salivary glands. So when the mosquito bites another person, it releases the sporozoids prior to it ingesting the blood. So clinical manifestations. Malaria has a broad range of clinical manifestations. It has a broad range. Malaria can present with almost anything. But for the purpose of treatment, we can classify it into two, uncomplicated and complicated. Uncomplicated one gives us the paroxysms of fever, which varies on the species. So if it is ovale and vivax, the fever occurs every 48 hours, so it's called tertan. If it's malaria, the fever occurs every 72 hours, so it's called quartan. While that of falciparum can occur within every 24 hours. It has a very bizarre appearance of symptoms. So that one is called quotidian. So you have fever, fatigue, rigors, sweats, headache, mild abdominal pain, nausea, vomiting, pallor, and even diarrhea. But take notes. The symptoms of malaria occur due to the rupture of the schizons. So the febrile paroxysm, this one they coincide with rupture of the schizons. And like I said, every 48 hours is vivax, and every 72 hours is P malaria. Now for falciparum, the periodicity is less apparent. So the fever paroxysms are quite bizarre. Okay, but it looks more of tetan, and the form is usually sometimes used to describe as malignant tetanus fever. Look at it. So you can see those occurring every 48 hours is the Vivax and the Valley. Those occurring every 72 hours is what? P malaria. And those are occurring at irregular intervals is what? P falciparum, which is one that predominates in West Africa. So P falciparum causes the most severe form of malaria. For some of the reasons, one, P falciparum can infect both mature and immature RBCs. Second, RBCs that are infected with P falciparum begin to form what they call knobs. So their membranes begin to bleb out, and they have increased expression of they simulate increased expression of intercellular adhesion molecules. Okay, so there's site of aggregation. So the red blood cells infected with lymphocytes clump within small arterioles and capillaries. Now, depending the organs that this occurs in, then gives us the clinical presentation, especially in the form of severe malaria. P vivus and P ovale, they usually infect immature red blood cells. P malaria infects only mature red blood cells. Remember, vivus and ovale can present with hypnozoites, which will be dormant in the liver. So these malaria infections are usually mild. So, clinical manifestations. It can be rarely prenatal because one, the mother takes the intermittent therapeutic prophylaxis, which consists of Fancida. Two, because the mother is in an endemic country, she already has some antibodies that helps, antibodies that cross placenta. Three, breast milk also contains some antibodies. For fetal RBCs contains hemoglobin F. Hemoglobin F is not so favorable for the malaria parasite to proliferate in. Five, usually mothers try to keep themselves in an environment that prevents exposure to Plasmodium falciparum, exposure to the mosquito that is the vector. Okay, but congenital malaria can cause spontaneous abortion, miscarriage, stillbirth, and neonatal death. Right. So the first signs of symptom usually about 2 weeks, but may occur as early as 14 hours. They include fever, restlessness, jaundice. You know, malaria, the parasite infects red blood cells. So red blood cells rupture, and the red blood cells rupture. What do they release? They release the hemoglobin, which can be broken down to bilirubin, giving them jaundice. Poor feeding, cyanosis, and hepatosplenomegaly. Hepatosplenomegaly. You know that one, the malaria parasite itself, what do? They infect the liver. Now, the response to malaria usually is cell-mediated, involving the lymphocytes. Macrophages are present also within the spleen. So when I say hepatosplenomegaly, one, it could be due to the parasite itself. Two, it could be due to jaundice. We know that hemolytic anemia, part of the triad of hemolytic anemia is jaundice, pallor, and hepatosplenomegaly. So it could be due to the hemolysis that's ongoing. The abnormal red blood cells are phagocytosed by the splenic macrophages. So complicated malaria now. Complicated malaria is diagnosed when we have a clinical or laboratory evidence. So we could have hyperparasitemia, greater than 5% of the sexual forms of the plasmodium, but hypoglycemia, not less than 40 milligrams per deciliter or 2.2 millimoles. Severe anemia, hematocrit less than 15%. Hemoglobinuria, usually present as coagulous-colored urine. So hemolysis reduces hemoglobin then enters the kidneys, which can cause kidney damage or present with Coca-Cola colored urine. Renal failure, hyponatremia. So the type of hemolysis that causes malaria is intravascular hemolysis. The hemolysis could be intravascular or extravascular. Intravascular is also called extracorpuscular because the hemolysis does not occur within the macrophages. or while extravascular is called intracorpuscular because the red blood cells are being phagocytosed by the skin macrophages. So malaria, the one that predominates mostly is the intravascular hemolysis, even though there's some forms of intravascular hemolysis that also occurs. So what happens when red blood cells rupture, they release the hemoglobin. So we first see hemoglobinemia. If you take the blood of a patient with hemoglobinemia, it usually appears bright pink. Then what happens after that? Haptoglobin binds free hemoglobin molecules. So we then have a drop in the free haptoglobin level. So we have hemoglobinemia, drop in free haptoglobin. The hemoglobin then gets filtered to the kidneys. Within the kidneys, some of them are passed in urine, and we say what? Hemoglobinuria. So the tubular cells then absorb the hemoglobin and convert them to hemosiderin. And then the tubular cells die, release hemosiderin. So we might see hemosidenuria. So hemoglobinemia, drop in free haptoglobin level, hemosidenuria, and hemoglobinuria. These are signs of intravascular hemolysis. So we might see renal failure. Renal failure could be due to formation of red blood cell aggregates involving the arterioles of the kidney, or it could be due to hemoglobin damage. Hypoglycemia, one of them is the consumption of, cause of hypoglycemia in malaria is consumption of glucose level by the parasite itself. Secondly, sometimes it will be ascribed to the treatment. One of the side effects of quinine is the release of insulin. Quinine stimulates insulinemia, hyperinsulinemia, which can cause hypoglycemia. Third, it could be due to hepatic dysfunction, the formation of these aggregates involving the blood vessel to the liver parenchyma. There's some form of hepatic dysfunction ongoing there, and the liver cannot produce glucose level. Okay. Then we have cerebral malaria, prolonged hypothermia, high output vomiting or diarrhea, and then if it occurs in pregnancy. So this is a form of cerebral malaria. You can see. Cerebral malaria is usually referred to as severe prostration. A patient in which every other intracranial cause has been ruled out and is positive for sexual forms of plasmodium. So features of severe malaria: prostration, loss of consciousness, coma. Features pointing to cerebral malaria: respiratory distress. Malaria causes respiratory distress, one, due to the presence of lactic acidosis, cause of anaerobic respiration, which could be due to shock. Secondly, because of what they call the non-cardiogenic pulmonary edema, that's what causes with what? Severe malaria, or even due to the severe anemia that's occurring, multiple convulsions, circulatory collapse, which is referred to as shock, pulmonary edema, abnormal bleeding, can cause some form of DIC, with platelets being used up, jaundice, hemoglobinuria, severe anemia, hypoglycemia, metabolic acidosis, lactic acidosis, hyperlactic acidemia. So metabolic acidosis could be due to dropping bicarbonate levels less than 15 or lactate levels greater than 5, what we call hyperlactocidemia, renal impairment and hyperparasitemia. Now, pathological features of cerebral malaria. We see engorgement of cerebral capillaries and venous with the parasitized red blood cells and the non-parasitized red blood cells, which we said before is due to the formation of aggregates. The brain is usually swollen post-mortem. Now, the cut brain is slate gray with petechial hemorrhages. Now, immunohistochemical studies suggests endothelial activation because there's increased expression of ICAM, disruption of the blood-brain carriers. The inflammation causes production of factors like communicative factor alpha, which increases the permeability of blood-brain barrier, inflammatory cell aggregates, and immune complex deposition. So, severe malaria pathogenesis. We've already spoken about it, but it's explained on one: excessive inflammatory process, sequestration of parasitized RBCs, cytoadherence through some proteins, leading to formation of rosetting and agglutination of red blood cells and their red cell deformability. To look at it, this is pathology of cerebral malaria. You can see multiple hemorrhages, tiny petechial hemorrhages. Like we said, there's excessive serum and tissue levels of tumor necrosis factor alpha and interferon gamma. TNF alpha is produced by the macrophages, interferon gamma is produced by CD4 lymphocytes. So we can see the trophozoites and schizons. This is what I said before about red blood cells infected by Plasmodium falciparum have formation of knobs, and then there's increased endothelial expression of interstellar adhesion molecules. This leads to attachment of these infected red blood cells to the capillary venules. So you can see the rosette formation, you can see the clumping. So diagnosis, peripheral blood smear as the gold standard. So we have multiple thick and thin films. We have dipstick tests, complete blood count show anemia, leukopenia, and leukocytosis, but there's no eosinophilia because malaria is not a helminth, it's a protozoa. So diagnosis game stains means of peripheral blood, both thick and thin film. Now, thick film identifies the degree of parasitization. Thin film identifies the Plasmodium species. Alright? So the best time to obtain it is usually after a febrile paroxysm because that's when blood has been ruptured. A single negative blood smear does not rule out malaria after repeat smear. Okay, so we can see the slides. You can see that we'll see many red blood cells with ring forms inside. And you can see the neutrophils here and the lymphocytes. Ring forms are small and indicate about 1/5 of the size of the red blood cell. And it's quite common to see multiple rings just in one red blood cell. So multiple rings in one red blood cell, some with single rings. You can see here the PMNs, see here the lymphocytes. So degree of parasitism. You count infected RBCs in relation to the predetermined number of the BBCs. So an average of 8,000 per micromole is taken as standard. Now 200 leukocytes are counted in 100 fields. That's 0.25 microliters of blood. So all parasite species and forms, including both sexual and asexual forms, are counted. So counting both the gametocytes, counting both the sexual forms, the trophozoa species within the RBCs. So a number of asexual parasites per new volume of blood spread as a thick film are also counted. This is the L and Perez method to get the parasite density. So basically we are counting the parasites, all forms of the parasites, by taking a certain quantity of blood. Now what we do is that we count the infected RBCs in relation to the predetermined numbers of WBC. Okay, so the usual predetermined number of WBC we take is about 8,000, which is the standard. So we count 100 leukocytes in 100 fields, and then we make a comparison. So see, when we see 1 plus, we see about 10, and we see about 1 to 10 the numbers of Plasmodium within RBCs per 100 thick fields. When we see plus plus, we see about 11 to 100 per 100 thick fields. When we see triple pluses, we see about 1 to 10 per thick field, and when we see 4 pluses, we have 10 per thick field. So when we take our slides, which is usually the thick films, and then we count them, and we see that okay, about 1 to 10 numbers of trophozoites or the sexual forms present per 100 thick fields. That patient has 1 plus. Okay, so if the patient has like 4 pluses, it means that are greater than 10 numbers of counted trophozoites or sexual forms per thick field. Other investigations, cause of the complications, so to check for urinalysis, hemoglobin. Urinalysis shows presence of hemoglobinuria, blood glucose level for hypoglycemia, total blood count and differential counts, serum bilirubin, creatinine, LFTs, so on and so forth. So the treatment on complete malaria is to cure the infection, to prevent the emergence of resistant anti-malarials and to prevent the spread of resistant anti-malarials. Severe malaria is to prevent death, to avoid minor adverse effects, to prevent neurological deficit, to save mother's life in case of pregnancy, to prevent recrudescence. So when we treat malaria, we assume we've treated malaria, but the treatment wasn't complete or was subpar. Someone could have a reactivation of malaria that was already present, and that's what they call, and that's what we refer to as recrudescence. Okay, recrudescence is the revival of material or behavior that had been previously stabilized. So we've assumed we've stabilized the patient, treated the patient with malaria, and then the patient has a repeat onset of symptoms. We call it recrudescence. The term relapse is usually referred to as for vivax and ovale, in which the hypnozoids are activated and then cause symptoms. So treatment, one complicated malaria is usually the artemether combination therapy, usually made up of artemether and lumefantrine. That's the usual first line. So the lonart, the coartem, they have the artesunate and amiodarquine, usually comes in form of camosunate, of the artemisonate and mefloquine. So that's the first line, artemisinin combination therapy. Second line is quinine. Severe malaria is treated with either quinine or artemether, but the gold standard for severe malaria treatment is artesunate. I'm sorry I left it out here. Artesunate, IV artesunate is the gold standard first line. Second line, we can use IM artemether, then IV quinine. So basically three parts: prevention to reduce man-mosquito contact, to control vector, and then use drugs. So stay indoors, clean windows and doors, gloves, socks, non-stick dresses, insect repellents, permethrin treated deadness, permethrin treated deadness. This permethrin are things that paralyze the mosquitoes so they can move. Vector control takes a breeding site away, so clear bushes, remove stagnant water. Very, very important. One of the ways malaria was cleared in the early Roman Empire was by getting rid of stagnant waters. Okay, then you use our local insecticides, clear drains. So it's important to give adequate and appropriate anti-malarials. While treating malaria, if you're treating severe malaria, so after the patient is completed the course of IV artesunate, you're advised to then commence the usual course of orals. Usually the ECTs are taken for 3 days. Okay, the first dose is taken at 0, second dose at 8 hours. For the first day, the second day they're taking 12 hourly, and it's good to take it with meal. Meal, especially fatty food, increases the absorption of artemether and lumefantrine, so it's very, very important to take it with meal. Alright, so chemoprophylaxis now is for proguanil. It's just done with proguanil. Now, for people that are still in endemic regions that are healthy, they don't need chemoprophylaxis. But for pregnant women, people that have sickle cell disease, people that are immunosuppressed, and travelers coming to endemic areas will most likely need proguanil as prophylaxis and pyrimethamine. Thank you very much.